Hello, my name is Amira Ogogeri. I'm a second-year internal medicine resident at NCH. This is my poster presentation titled Denosumab, a culprit of severe pancreatitis with multi-organ failure and severe hypocalcemia. Osteoporosis is a metabolic bone disease characterized by low bone density and skeletal fragility, leading to an increased risk of fractures. Denosumab, also known as Prolia, is a human monoclonal antibody initially approved in 2010 for the treatment of postmenopausal women with osteoporosis and high risk of fractures. Despite denosumab's proven effectiveness, its administration has been linked to a spectrum of rare yet grave adverse reactions. Among these are hypocalcemia, atypical femoral fractures, and osteonecrosis of the jaw. Additionally, pancreatitis has been reported, although exceedingly rare. Our patient is a 70-year-old female with a past medical history of osteoporosis, presenting to the ED with 3-day history of progressive abdominal pain, intractable nausea, and non-body emesis. She reported being on denosumab injections as well as vitamin D for osteoporosis. She received Prolia shots over the course of a year and a half, the latest 4 weeks prior, with no adverse reactions. Her vital signs were stable. Initial labs showed severe hypocalcemia at 5.1 with a low ionized calcium at 0.69. Additional lab work showed significant elevation in the creatinine, amylase, lipase, lactic acid, BUN, white blood cells, and hyperparathyroidism with normal levels of AST and ALT. CT scan of the abdomen pelvis indicated acute pancreatitis and cholelithiasis. Abdominal ultrasound showed multiple gallstones. EKG displayed a normal sinus rhythm with prolonged QTC at 498. Physical examination showed generalized abdominal tenderness without guarding, a positive Fostek sign, and negative Trousseau sign. She was treated with calcium gluconate 1 gram IV in addition to IV fluids and dilaudid for her pain. Her condition improved and she was admitted for further inpatient care. Overnight, the patient became hypoxemic, requiring nasal oxygen. She reported a recurrence of the epigastric pain, the nausea, and the intermittent lower extremity twitching. Repeat serum calcium was undetectable. EKG showed further prolongation of the QTC to 559, and a second dose of calcium gluconate 2 grams IV was administered. The patient's condition continued to deteriorate with increased work of breathing and persistent abdominal pain. DTRs decreased throughout all limbs, and worsening twitching was noticed in the right arm. Repeat EKG showed further prolongation of the QTC to 571. The patient was transferred to the ICU due to multi-organ system failure with refractory hypocalcemia and concerns for hypocalcemia-induced arrhythmias. A central line was placed and calcium gluconate infusion was initiated. CRRT was started due to a neurorenal failure and multiple electrolyte and acid-base disorders, which was eventually switched to HD. A repeat CT ruled out necrotizing pancreatitis with retroperitoneal hematoma, however revealed worsening of the peripancreatic inflammatory changes. An MRCP showed severe pancreatitis with a large pseudocyst compressing the stomach. Gallstone pancreatitis was ruled out with a HIDA scan showing no evidence of cystic duct obstruction, MRCP showing cholelithiasis and descending gallbladder, however no ductal dilation or common bile duct stone, and no pancreas divisum. Calcium levels gradually improved and infusions were eventually replaced by PO calcium supplementation. QT's prolongation also resolved. White blood cell count started downtrending and the IgG4 was negative. Renal functions and urination were gradually restored and HD was discontinued. The patient's symptoms and the abdominal pain slowly improved with less opiate requirements, and her diet was advanced. This case reports a severe case of hypocalcemia attributed to denosumab-induced pancreatitis after all other possible causes of pancreatitis were ruled out. This complication of denosumab is considered extremely rare and was reported to be about 0.2%. Several of these patients had a prior history of pancreatitis. This case emphasizes the necessity of further research needed to understand the mechanisms of denosumab-induced pancreatitis and identify preventable factors to mitigate this serious risk while still leveraging denosumab's benefits. Thank you.